Hello, everyone, and thank you for joining. Thank you for joining ICT's Virtual Town Hall, Pathways to Healing, Expanding Access, Elevating Education, Empowering Communities. We're honored that you've chosen to spend this time with us today for an important conversation on the health challenges and solutions shaping Indigenous communities today. To make this hour as meaningful as possible, our team has developed a resource guide packed with tools, data, and insights shared by today's speakers. So be watching your inbox after the event, as we'll be sending the guide out to every registered attendee. I'm Haley Martinez, Donor Relations Director at Indig Public Media, ICT's parent nonprofit organization. My work centers on building relationships and securing the support that keeps ICT's Indigenous-led journalism free and accessible to everyone. While our news costs nothing for you to read or watch, just as we believe it should be, it is not free to produce. We rely on the generosity of our partners, donors, and viewers like you to keep vital Indigenous stories in the spotlight. We thank you for being part of that circle of support. I'd like to specifically thank the W.K. Kellogg Foundation for supporting this event and the Native Organizers Alliance for their very generous $5,000 event sponsorship. Your support helps amplify Native voices in healthcare and beyond by making it possible to host more community-centered events like this one. And now I'm delighted to introduce you to the newest member of our leadership team, Katie Oyen. A proud citizen of the Oglala Sioux tribe, Katie became president and CEO of Indig Public Media and chief editorial officer of ICT this past Monday, June 23rd. With more than 20 years at the Associated Press, including national editorial leadership, Katie brings deep experience, sharp vision, and a steadfast commitment to Indigenous storytelling. Katie, we're thrilled to have you guiding our next chapter. And now I'll hand things over to you to share a little bit more about yourself and kick off today's event. Thanks, Katie.
Thank you so much, Haley. Sorry, took me a second there. Thank you for that wonderful introduction, Haley, and thank you all so much for being here. I previously worked at ICT as managing editor, and I'm so thrilled and honored to be rejoining this amazing team, and at such a crucial time for public service journalism and for Native journalism in particular. As Haley mentioned, Indig Public Media is the nonprofit organization that supports ICT in our capacity to produce compelling Indigenous news through daily digital stories on our website, ictnews.org, and weekly broadcasts on the ICT Newscast. And while today is first and foremost about sharing meaningful insights and information, it's also a fundraising event to help advance our mission. From expanding local news coverage to creating career pathways for the next generation of Native journalists and newsroom leaders, your support makes it possible for us to power strong, local, Indigenous-led journalism together. Every contribution, big or small, helps us continue to amplify Native voices and report on the stories that matter most across the Indigenous world. If you feel moved to give, you can donate at any time during the event using the link that will appear at the bottom of your screen. And now I'd like to pass things over to today's moderator and ICT's managing editor, Jordan Bennett-Begay. Hi, Jordan. Thank you.
Hi, Katie. Thank you so much. I know the team is so happy to have her leading us, and we're excited, for what the future holds. Hello, friends and relatives. Jordan Bennett Bigayan Shek, Ani Yashla, Madishkishi Bashishi, Nakarina Dasache, Oze Tachini Dashanella. I'm Jordan Bennett Bigay, managing editor of ICT. And so much for joining us today. I'm really excited to talk about all things health, public health, and policy, especially under this new administration with our expert panel. For you listeners and viewers out there, we'll leave about 10 to 12 minutes in the end to answer any audience questions. So please use the Q&A box in the chat next at the bottom of your screen, and we will do our best to get to them. For right now, this is our panel. First, we have Abigail Echohawk. We have AC. Hello, AC. We have AC Locklear, CEO of the National Indian Health Board, followed by Abigail Echohawk, who is the director of the Urban Indian Health Institute. And then we have Dean Seneca, CEO of Seneca Scientific Solutions. And thank you so much for all of you for being here today and just to help us understand what's going on.
Thanks for having me.
Yeah, no, thank you. Okay, so we have little time, so let's just jump into it. And my first questions to all of you. So it has been 5 months in the second term of the Trump administration, and so much has happened from the Indian Health Service layoffs and to those being rescinded, medical research grants being canceled, and just everything across the spectrum that we'll get to later in the discussion. And all of this under Robert F. Kennedy Jr., who's the Secretary of Health and Human Services. What are your initial reflections on the impact of the policy so far, and how has it affected the work each of you do every day and who you serve? I guess, AC, you can definitely start us off.
Awesome. Thank you, Jordan. Thanks so much. And thanks for having us. Yeah, for sure. At the National Indian Health Board, it is our mission to advance health and well-being for American Indians, Alaska Natives through policy and advocacy. So these decisions and every decision that any administration makes is, really critical to our everyday work. But, with the changes at the beginning of the administration, it led to a lot of uncertainty for a lot of the tribal nations. It led to a lot of confusion. Tribes really depend on a lot of these funding mechanisms to really help advance the needs of their people. So with a lot of the funding freezes, potential staff cuts, it really left tribes in a place where they didn't know if they were going to be able to continue a lot of that funding or a lot of this programming. And for us, that means that we were constantly working with our partners, constantly working to educate the administration, educate Congress, get folks on board to make sure that we were exempting tribes from a lot of these policy decisions. And something we'll probably talk about a lot today is what makes this a little bit different is the federal government has a trust responsibility to the tribes that's different than any other population. And these programs are essential to upholding that trust responsibility. So any of these decisions without consultation of the tribes is a violation of that responsibility. So it really has been about really educating those, protecting those programs, and really holding on to what we can and making sure that we're keeping tribes unharmed.
Mm-hmm. Abigail, did you have anything?
Yeah, so thank you so much for that question, and thank you for the invite to be part of this incredible panel. And I hold a really unique position. I hold two positions. One is the Executive Vice President of the Seattle Indian Health Board, where we are contracted by the Indian Health Service to provide primary care, social services, and traditional Indian medicine for people living in Seattle, American Indians, and Alaska Natives. We are an IHS contracted facility. And in that sense, since this administration has started, we have had our money frozen off and on. We've had threats to whether or not we're going to be receiving funding. We have lost the connections to people who provide us our technical assistance to ensure that our grants are carried out appropriately. And so we've suffered in that sense. We are not receiving the prepaid benefit that we have through our treaty and trust responsibilities that the federal government is supposed to provide to us to ensure the health, wellness, and safety of our relatives that we serve every single day. And that's a deep concern. And so we have actively partnered with organizations like the National Indian Health Board to fight for our rights, to fight for what our relatives survived so that our people today could thrive. We are fighting for that actively now, and we have seen the administration respond when Indian country has come together and pushed in these coalitions that we are all a part of. And I am so grateful and proud of our tribal leadership and our organizational leadership who have really stepped up. In my other role as the director of the Urban Indian Health Institute, a tribal epidemiology center, which we focus on data for Indigenous people by Indigenous people. And our access to that data has been limited. We know that the administration removed data sets, information that we need on our relatives in order to understand where their health and well-being is so that we can do better for them in the future. And not all of that has been restored. Again, this is a violation of treaty and trust responsibility, and the education that is needed for this administration is one that we are actively working on, but we're just in the beginning. But I do want to say, despite all of those threats, the joy, the collaboration, and what Indian country has done in stepping up together is something that continues to give me incredible hope.
Thanks, Abigail. Dean, what are your reflections?
Well, I want to thank Indian Country today for having me on, Waiso Yahweh, and I'm very honored to be part of this powerful warrior panel. I don't believe the Secretary is negotiating in good faith. He has a record riddled in contradictions, falsehoods. To me, he can't be trusted. He erodes trust under the disguise of trying to restore it. Treating him as a serious partner for Indian Country could have devastating consequences. So I think that we have to keep our guard up. I'm really overwhelmed, let me just say that, with what he's done with vaccines and our vaccine immunization committee. We still don't have a CDC director. I understand that there are hearings going on today. As we speak, the new ACIP is formed, staffed with people who are questionable or have questioned vaccines, who are anti-vaxxers. So, you know, this is our biggest public health tool that we have in fighting many infectious diseases, and this is being something that's undermined. So I have some serious concerns about what's going on now at the department.
As of a lot of like Native people and tribal leaders, and I know one of the big topics, I mean, you all brought up was also the public health. And, you know, since the start of this new administration, the American public health infrastructure has been dismantled from the top down, from the CDC Healthy Tribes program, scientists being let go, and again, like you said, vaccines. And I guess this question's for Abigail first. For listeners who haven't heard about the CDC Healthy Tribes program, can you explain like what happened there and how this impacts Native people?
Yeah, and so I'm actually an awardee under the Healthy Tribes program. I have multiple programs under that, both for locally in the area I'm in Seattle, and also for the work that I do nationally with the 41 urban Indian health programs across the United States. And so the Healthy Tribes program encompassed a multitude of different grants. We're all focused on chronic disease prevention, so things like diabetes, heart disease, obesity, and we were doing it through our own cultural ways. And so Healthy Tribes as a program established in the CDC is again the upholding of treaty and trust responsibility. We have a prepaid benefit to ensure the health and well-being of our people, and as a result of the harm of colonialism, we know that many of our people suffer from health disparities like diabetes. So putting that program in the CDC was the federal government upholding treaty and trust responsibility. What has happened is they have laid off a majority of the staff. They're talking about reorganizing and shifting. For my programs right now, and I've talked to people across the country, we don't have the same resources that we had to coordinate with the CDC to ensure that we were fulfilling all of our financial obligations, that we could make shifts and adjustments to our programs. For example, we just hosted a large number of, it was a little over 20 folks from across urban Indian health programs, where we trained them on how to implement traditional foods into their programs and into their clinics. Those are essential to our people's healing. And so when we think about the public health infrastructure, that's like the white word for it, like public health. What does that even mean? My parents were the very first public health practitioners I ever met. They fed people, they took them to doctor's appointments, they housed them. It's all about taking care of our people and the community. And so while it may be dissolving across the nation right now, we are going to fight to uphold it. We will not let it be done in silence, and we won't let them do it, honestly. But the thing that we have to hold on to is we have it in our own communities and we maintain it. And so we need to hold on to that cultural value of taking care of our people. And we saw it during COVID-19. American Indians and Alaska Natives, we did it best, and we will continue to do so. But we will fight for treaty and trust obligations to be upheld, and restoring the Healthy Tribes program at the CDC is one of my number one priorities.
And then Dean, you worked at the CDC for nearly 20 years. I mean,
20 years.
Yep, 20 years. So whether offices or programs in the CDC have been affected by this administration that we cannot see right now?
Well, for one, they were supposed to have a tribal consultation meeting in the winter. That has never happened. The other thing I do know is that there were tribal liaisons at each center. Those have been eliminated. Many of the offices had a lot of programs that were going on in Indian country, like the Injury Center, which is the second leading cause of death in our communities. That program has been eliminated. No, there's a lot going on. And then, my understanding, and this may have changed, everything changes every day. Damon Kilsback, who is the director of the Office of Tribal Support there at CDC, is a commissioned officer. And my understanding is that everybody is supposed to report to work on campus. And CDC right now doesn't have the facilities because they've been actually, for the last 20 years, trying to get out of renting all of these additional facilities for people to come to work and having more people work at home. Now they want everybody to come to work, so they're like compiling 3 or 4 people in a single office. But my understanding is that the commissioned officers don't have to report on site to work. So from what I understand is that Damon lives in Montana, and I actually like Damon, but the CDC is in Atlanta, Georgia. So how is that working? And then how does that work with all the commissioned officers throughout the whole country if they don't have to report on site at their job, but everyone else has to? And as you know, Indian Health Service is flooded with commissioned officers, and in my opinion, too many. I really do think that those resources could be broken up and given to our tribal governments and our healthcare systems, to do good work, because in many cases these commissioned officers are overpaid, underworked, and don't do enough for our communities. For example, one commissioned officer at a tribal health facility gets paid about $200,000. We could hire 3 or 4 people with that amount of money and get a ton of stuff done in our tribal communities. So, I just feel like there's a huge double standard here. But as far as CDC, I keep hearing insights throughout the whole agency, and my favorite one when what that was going on when this reorganization happened was that several senior leaders actually called me and said, Dean, I've been let go from my position, but I've been offered a job to work in Indian Health Service in Alaska. So, talk about a smack in the face or kind of degrading our indigenous health system. It was just awful on so many levels. So, and then my understanding when I was watching some of the congressional testimony for a new CDC director, he's looking at cutting the budget in half.
Oh, that's interesting. Well, and I think we're gonna talk about that soon. But I mean, in terms of the IHS bringing in more people who are health leaders and I guess reassigning them, have you all heard any updates about that? Because I know from understand a lot of them are being offered reassignments in like Montana, Albuquerque, just across Indian country. Is that Dean? You said it's pretty much like a slap in the face, and I know I read reports saying it's an insult. But there's also the other, part of that narrative that there are open positions and we need people in there. I mean, how do you argue that? And any of you who have insights into that?
Yeah, I'll just start on that. First, I want to say that Damon Kilsback has been an incredible advocate for us, and I know will continue to be, and we are appreciative of the work that he has done. But when it comes to this specific issue, I've talked to numerous people who received those letters that said you're now being removed for this, but you can have this job at IHS. So why did they do that? So on average, the IHS across facilities and actually within the offices in DC has an incredible number of vacancies. In some places, it's as high as 25%. And so while this was a misguided effort to fill those vacancies, what we should have done is and these folks should have had the opportunity, instead of being told, they should have had the opportunity to say, these are other opportunities, not show up for work here in 3 or 4 weeks, otherwise you don't have a job, which is what some of them were actually told. And so we are seeing people shift into positions that they don't have the qualifications for. They may have a PhD in something that doesn't relate to the operations of what they've now been assigned to at the Indian Health Service. So while we have the vacancies and Indian Country has been fighting to have them filled, we need appropriately qualified individuals to fill those positions. And that is what we are fighting for. Not just somebody who honestly is probably a great person, doesn't know anything about this job, but is just trying to keep feeding their families. So yeah, they may relocate. And for others, they lost their jobs. And that means that they and their families are suffering. And nobody in this country, regardless of race or ethnicity, deserves to have that happen to them and to have their livelihood taken.
AC, I don't know if you had anything to add to that too.
Yeah, absolutely. Abigail is spot on with that. It was definitely a misguided way to fill those vacancies. There's, like she said, it's upwards 20, in some facilities it's 30, 35% vacancy rate. And those are everything from your doctors, your physicians, your nurses, all the way down to your coders, your billers, the sanitation folks who are cleaning the facilities. And, we are in a system that is already at its breaking point. I mean, we can't ask folks who are just completely, unqualified to come into a system and just fill a spot when we need qualified physicians, qualified nurses, qualified folks to come in and fill these vacancies. And, right now, it was reported about 43% of IHS facilities are one provider away from having to shut their doors. So if there is a sick day, if someone calls out sick in some of these facilities, a physician, emergency room physician, they have to shut down the hospital. There's no way they can stay open. That risk accreditation issues, that risk, think about, a grandmother who is starting in the early stages of a heart attack, who is coming to an emergency room for services. The closest hospital is now 2 hours away. There's no way she's going to be able to live. Those are the realities that we are facing. And it's not even a question. We shouldn't even be, thinking about that as the biggest issue. Right now, the issue is IHS has a hiring freeze. Even if they were able to get an exemption for physician level providers, the doctors, but that's only a small part of what keeps a hospital and a clinic going. You can't have a doctor who is, putting patients into a room that isn't clean, that isn't sanitary. We can't hire those folks who are necessary to keep the hospital going. And, we are working to really, push for those exemptions, but we're still in a position right now where I just can't hire anyone. The reality is the hiring of the physicians and those upper level providers is going to be hard. It's rural America. We're asking, there isn't the infrastructure there to provide housing for doctors. There's so many different issues. But that's aside from, we can't even hire folks to come in and clean. We can't even hire IT specialists to keep the facility going. So it's really about our accreditation, maintaining safe facilities, and keeping the doors open.
Mm-hmm. And all these systems are really interconnected, because I think, if you have doctors come out sick, way to prevent that are vaccines, and that's being attacked, and chronic illnesses. It's just very ironic. And I think a lot of this has me thinking about these tribal epidemiology centers you all brought up earlier. This program was authorized by Congress in 1996, and they were formally given public health authority in 2010. And this would give them, access to information for disease surveillance. But what's going on with the CDC? I'm curious if the tribal epidemiology centers will step it up, or if they should be relied on more, because they're technically an extension of sovereignty. And Abigail, since you work with a lot of them, are there an underutilized resource now, or can you provide insight into this?
Yeah, so I direct a tribal epidemiology center. There are 12 in the nation. They fall into all of the IHS regions, and all of the epidemiology centers are overseen by the tribes in their area through a tribal board. So they are an extension of tribal sovereignty. I operate the Urban Indian Health Institute, which is overseen by a board of directors that represent urban Indian organizations and individuals. And so mine is the only one with national scope for the more than 75% of us that live off reservation. We're just tribal people living off reservation, and it doesn't mean treaty and trust obligations ended because we stepped off our reservations. And so the tribal epidemiology centers, if you don't know what epidemiology is, epidemiology is the look at, the Western perspective sees it as a study of disease over time. Like, what are the trends? Where can we intervene? What are things that happened? But from an indigenous perspective, it's a study of our thriving over time. We all hold the stories 5, 10, 20 generations back of how our tribes and our families did more than survive. We thrived in so many ways. So that's what the tribal epidemiology centers do, is uphold an indigenous perspective on how we gather data and information. We do it for the good and well-being of our people, and is overseen by our tribal communities. We are underfunded and under-resourced, and our funding, like everybody else's, is currently under threats. And so things like the dissolving of the Healthy Tribes program had a section of it just for the epidemiology centers to provide resources and support on health and wellness within Indian country. So we're being threatened. During COVID-19, the information that Indian country got, the contact tracing, for example, the CDC initially during COVID-19 put out recommendations that you needed warm water to wash your hands with. Well, they didn't change that for 3 months when they finally recognized that some people don't have access to running water, let alone warm water. And it was the tribal epidemiology centers who stepped in. So we are actually suffering as a result of the changes in the administration, and we do and step in and step up wherever we can, but we are also limited as a result of this. So I also want people to know that rather than resources for individuals, which you can go to our websites and download things on like measles and stuff like that, we really do provide the resources and support for the tribes at a larger scale. And while there's individual resources, it really is the support for tribes and urban Indian organizations. And I'd like to see the administration increase. And again, in upholding treaty and trust responsibility, if they're going to be cutting the CDC, they should be increasing the funding to tribal epidemiology centers.
No, I agree with that. I mean, I said they're an extension of sovereignty, all those treaty and trust responsibilities. And even like tied to that too is, I think, the question of biomedical research. I mean, Trump cut grants that were related to diversity, equity, and inclusion. But 2 days ago, a federal judge in Massachusetts ordered the administration to restore about 800 U.S. National Institutes of Health research grants it had canceled. I mean, that's definitely not all of them. But Dean, I'm like wondering, how important is biomedical research for Native people and tribal nations, and how will these cuts affect them?
Biomedical research is essential for our tribal nations, because we don't really have a lot of research or study in our communities. But I wanted to step back for a second on that question. CDC does an NHANES study every year or every 2 years throughout the whole country. And this is where you get the average statistics, average height, average weight. And they do different racial ethnic group NHANES studies. My first day at CDC, 25 years ago, my first question was, well, where is our indigenous, or where's our American Indian, Alaska Native Hawaiian NHANES? And we still haven't had one. We haven't had an NHANES study, so we can't even tell, like, what are the averages when it comes to our Native populations, right? We don't even really have a baseline to really build off of when it comes to that. So that's critical. But biomedical research for everything to really get understanding, how, diabetes is really impacting our communities. Heart disease and stroke is really impacting our communities. Chronic liver disease, and a lot of other social determinants of health. All of this, because we really don't have answers, because we really haven't done research. And the other research that we really need to do is to assess our cultural traditions and their impact on health. We know that our culture works in healing, and we know that a lot of things that we do in our communities are very effective to addressing trauma and reducing disparities. But we need to prove that to these NIH scientists. And that's what research that I think that we need to really engage in when it comes to making an impact for our tribal communities.
Okay, that's good to know. I wanted to circle back, AC. I mean, you mentioned we were talking about Indian Health Service, and a lot of this is tied to funding. And so, like I think a little over a week ago, Congress approved advance appropriations for AHS for 2024 and the 2025 fiscal years, but we're still looking at 2026 and 2027. Can you explain what is going on? What's the good, the bad, and what does this mean for our cousins, aunties, elders back at home?
Yeah, for sure. So, Congress is actually in, I think, December 2022, Congress, for after about a decade of advocacy by tribes, by organizations, um, passed advance appropriations. And what this means is that every year Congress appropriates funds to the Indian Health Service. So every year at the beginning of the fiscal year, Congress has this process that we're going through and seeing right now, in which they provide the funding. Um, what that means is, though, is those years in which Congress cannot agree on funding or misses their deadline or there's a government shutdown, that means our hospitals and our clinics close. They can't provide services to our people. That means, our aunties can't get their medicines. Our family members who need prenatal care can't go to their facilities because they aren't open. Advance appropriations essentially provides funding in advance for the next fiscal years, which means that in those instances, if there's a continuing resolution or a government shutdown, Indian Health Service is going to have their money and they're going to be able to continue those services. It's not all of the services that Indian Health Services provides. There's some that do not have advance appropriations. And most recently, why it's important and why it's a topic right now is that in every year in every appropriations they have to continue that. There has to be a vote to continue it for the future years. And in the president's most recent budget proposal, he did not include advance appropriations for 26 and fiscal years 27. So that means that what he suggested to Congress is that advance appropriations no longer happens for Indian Health Service. And that is just really taking us so far back after decades of advocacy. We need to be moving forward. We need to do it needs to be mandatorily funded so that it means that we don't have to go through this process every single year, that they have to fund Indian Health Service and there is no government shutdown impacts. There is nothing like that they fully fund and they fund it every year. Luckily, we have a lot of folks in Congress who are supportive of Indian health. Um, you know, Chair Tom Cole, who is a tribal member, has been an outspoken advocate. He is also the chair of the Appropriations Committee for advance appropriations. And when it was acknowledged and brought to his attention that it wasn't in the president's budget, he made it very clear that him and the other leaders of the Appropriations Committee supported advance appropriations for Indian Health Service. So we're really optimistic that it will continue as we get ready to see this bill pass in the coming days. But it is something that we have to continue to push for all of our representatives at this time to support advance appropriation and make sure that it is in every future bill until we're able to push mandatory across. Because we have seen so many harms done to our people because of government shutdowns.
Yeah, no, definitely. I remember most recently 2019. I think everyone learned from that. And there's also a follow-up question. I mean, there's the One Big Beautiful Bill Act that was passed in the House just last month in May. Now we're waiting on the Senate. They're trying to go through it, and part of that is it makes cuts to healthcare. Medicaid is a huge part of those cuts in the bill, and it could affect a lot of Native people, especially in rural areas. I mean, what is NIHB doing, seeing and doing, and can you break that down for us?
Yeah, for sure. When Congress and the president really set out to design this bill, they made it clear that they wanted to make cuts to a lot of these essential programs that provide services, Medicare, Medicaid, SNAP as well. And when the initial bills and the initial bill text, we were looking at slashing Medicaid to an astronomical extent. And why that's important for Indian country is Medicaid is the single largest payer for Indian health service. The Indian health service is grossly underfunded by billions of dollars. And the only way that our tribes, our urban Indian clinics, our other facilities, our tribal facilities make up for it is through this revenue that they get from third party insurance providers, Medicaid being the greatest. And for everyone, these changes that they were proposing would mean adding work requirements to Medicaid and SNAP, which would create new barriers for access for low-income individuals, including many Native people. It included pushing state-level costs to cost shifting to the states, which is another barrier. And what we have been doing in the National Indian Health Board is we've been working with a coalition of partners, folks like Abigail at the Urban Indian Health Institute and Seattle Indian Health Board, to really make sure that we are working with Congress so they understand that tribes should be exempt from a lot of these requirements. We are able to have these benefits because of the trust responsibility, and those really make up for the inability for Congress to fully fund Indian health. So unless they're going to fully fund Indian health service, we need to preserve all these benefits for our people and make sure that they have those. So we've been pretty successful in getting exemptions to work requirements, exemptions in SNAP program. So we've been able to work with our partners on the Hill. So we're really optimistic that as this bill comes down, as it will have great impacts on all of our relatives, not just our American and Alaska Native communities, but beyond, that through some of our advocacy, we're going to be able to protect our tribal communities from a lot of these new requirements.
Okay.
And if I
Thank
can
you.
add, Jordan, really quickly, my clinic, Seattle Indian Health Board, 54% of our funding, our relatives that we serve, 54% of them are on Medicaid. And so what does that look like in action? I got called up to our clinic not long ago where somebody wanted to see me, and there was a young person there. She had recently gotten custody of two of her young relatives who had been removed from their home. She was trying to get permanent foster care. And so she, who had already been a relative accessing our clinical care, brought these two young ones. And the reason they wanted me up there is we had finalized them in their primary care provision. And so that was the final step they needed to get these kids permanently located with their auntie, so they stayed in our Indian homes. And so upholding Medicaid and ensuring we have the resources and funding is upholding ICWA. Upholding Medicaid is upholding treaty and trust responsibility. Ensuring we're exempt from the work requirements and other things like that, that is the upholding of treaty and trust responsibility. And I want to be called up when I have two young ones like that and the little one tells me, I want to be a doctor, I got to hear the stethoscope. That love and that encouragement, they should be able to come to Indian clinics, receive cultural care, and have the resources they deserve. That's what our ancestors fought for, and that's what we'll fight for.
No, thank you. Go ahead. Yes, go ahead, Dane. Yes.
These cuts will devastate Indian country overall and really have an impact here in New York because we have traditional tribal nations here, which means they really govern themselves by chiefs, clan mothers, and warriors. They're not elected systems, and because of that, our tribal nations don't accept Indian Health Service, and they don't have the BIA, right? So they don't have these things, but they rely on the state. And they rely on the state of New York to provide these services for our tribal nations. And if you can imagine that, these services are, very basic clinical care. It's extremely underfunded, and the state only provides something like $25 million for 9 tribal nations and the largest urban Indian population in the country, New York City. So that's barely anything. That's barely enough money to keep the doors open. And I'm always advocating with our tribal leaders here to New York State for more money just to keep the doors open. So, any cuts to Medicaid, like the others have already said, in an already fractured Indian health system is just going to devastate Indian care for indigenous populations, and especially in New York State.
Well, and all this really makes me think of vaccines and then measles happening. I mean, RFK fired and replaced the CDC vaccine advisory committee that lacks experience. And my first thought about this was, what would this move do for Native people, especially elders and children? And could IHS even still distribute and administer vaccines because they're technically housed in a federal agency? And then, like you said, Dean, I think of all the Native people who are in cities or in urban areas, maybe away from IHS clinics or urban Indian health programs. I mean, what do you all think? What are your thoughts about this?
First, I want to say vaccines that are approved in this country right now have gone through extensive testing, clinical trials, and are FDA approved for safety and well-being. And so there are some vaccines, and everybody needs to look to see if they may have certain allergies associated with them. And that's where you spend time and talk to your primary care provider. But these vaccines are safe. They are essential, and they are absolutely key to the health and well-being of our communities. So the Urban Indian Health Institute, they just came in this week. I recently wrote a little kids coloring book with one of my youth interns on the importance of getting vaccines. And I remember sitting with him and he's like, what? These vaccines do what? And he goes out and tells all his friends, like, have you gotten HPV? Have you gotten all your vaccines? You know, we need to provide this education, and that public health information is key to what the CDC does, is providing up-to-date, scientifically based, evidence-based information. If we lose that access, we are going to see outbreaks of disease we have not seen in 100 years. And in fact, the county that I'm in, I was just notified yesterday, we're in the middle of a measles outbreak here. We just had 2 more diagnosed on Monday. That is an incredible risk, and one that is not necessary. So we call on the administration and Secretary Kennedy to uphold the most basics of evidence-based scientific practice to ensure that there's public health information and access to vaccines. It is essential to the health and well-being of our community. We know what happened 100 years ago, 200 years ago, 300 years ago in regards to this kind of disease. Our people were decimated, and I refuse to let that happen again.
And if I could add to that, vaccines do not cause autism. There are many studies throughout the world looking at hundreds of thousands of kids, over 1 million of kids in these studies, and not one link to autism. Because all these vaccine deniers go to the famous Wakefield study, which was totally corrupt, totally non-scientific, only had something like 12 kids when they were trying to make a link to vaccines and autism, and the study was actually funded by anti-vaxxers. So, and that's what everybody's basing all of their knowledge regarding vaccines on. But, I did a lot of measles work when I was in Ethiopia. And let me tell you, like Abigail said, these are totally preventable. I would be in one village and I would see 50 to 100 kids screaming and crying in pain because of measles. And this is totally preventable given the vaccine. I would go over to the next village and the community would be quiet and the kids would be playing because everybody was vaccinated. There's no need in this day and time for us to have any measles cases here in the United States. And to have conversations with these anti-vaxxers, it's becoming ridiculous. We need these vaccines. And also, most importantly, and this specifically applies to our indigenous communities, we have a lot of immune compromised people, like we had pre-existing conditions for COVID-19. Our populations need these vaccines in order to stay healthy and vibrant. So, yeah.
Okay, thanks, Dean. AC, did you have anything to add?
Yeah, I think Abigail and Dean hit it on the head, but I think one thing we always got to consider that sometimes it's hard for our people to trust the government, and I get it. Historically, it is, we do not have the greatest history with the government telling us to do anything. But you should trust the providers who are in your hospitals that have been taking care of you for years. You should trust the nurses, those who have the experience, who are telling you that taking this vaccine isn't just about you. It is an act of love to protect your community, your elders, your relatives. It's not just about how it protects you. So if anything, really just take that step, because as American Alaska Native people, we are expected to take care of one another. And this is an expectation in our community, and our ancestors and relatives have fought so long for us to have healthy communities and healthy people. And, we really need folks to take these vaccines and make sure that we can continue to be healthy.
Okay, thank you. Thank you all. But before we switch gears to take audience questions, we're going to take a quick 2-minute break. So we'll be back.
So when I first started at ICT, I was one of the first 5 or 6 employees, and I recall Mark Trahan, Jordan Bennett McGay, and I, sitting back to back, just pop, 3 little computers in a basement to go from, 5 employees to 40, 50 plus. To see our continued growth is just makes me really hopeful for what we're building.
We're still in an era when there's not a single Native American on broadcast news, not at PBS, not at NBC, not at ABC. And that vacuum, I think, is important for us to fill. There was a story that the Associated Press wrote that had a great headline. Indian Country Day has a new owner itself, and Indige Public Media is that owner. And really, it's not a separate entity in the sense that it's the same people. And we had a visioning exercise and basically started shopping for a name. And public media seemed to capture a lot of what we were trying to do.
ICT has shaped the way I see journalism. That showed me that diversity and inclusion is possible. I think up until recently, newsrooms were predominantly white male. A lot of things that aren't traditionally newsworthy are newsworthy to people, being from different walks of life.
One of the things that I just love is it doesn't take more than 10 minutes if you drop into a tribal community to see how much talent there is. And to be an avenue for that talent to grow is fabulous. ICT has always had a double mission. One mission is to serve the audience and just have information about tribal communities in a way that's important and useful. The second one that's equally as important is to build a platform for young people, for journalists. I mean, I want people to look at ICT on a tablet or on a website and say, that's where I want my kid to work when they grow up.
Hey everyone, we're back and I'm trying to sift through our Q&A box. So if you have any questions, just throw them in the chat right there, and we'll do our best to get to them. One of them stood out to me, and they're a nurse in upstate New York, but they said, I'm white, middle-aged, neurodivergent, queer, rural, low to middle socioeconomic status, and intermittently disabled. I'm looking for a way/place to work to provide health care and other support for Indigenous populations. How can I connect to and support this work with my time and knowledge, because I don't have the time or money to give at the moment. I don't have the money to give at the moment, sorry.
Well, I always encourage people that time is just as great a gift. I know that my organization, we rely on volunteers to assist us with things like fundraising events, many different things. So time is also a gift. And I want to thank her for that question, is that we all need to, that's what a public health community is. One who takes care of each other regardless of race and ethnicity, but the fact that we all matter and we should matter to each other as a community. And so there's multiple different ways where folks can contribute in those ways.
Okay.
Yeah, and I would say if they're in the New York City area, we have several urban Indian organizations in New York City. We have urban Indian organizations in Syracuse, Rochester, and Buffalo. We have 9 tribal nations throughout the whole state. And I am sure that, I know Native American Community Services in Buffalo would definitely welcome anybody that wanted to volunteer and, give their time to help improve Indigenous health.
Okay. AC, did you have anything to add for our audience out there?
Yeah, just to echo, I think there's so much information that we put out at the National Indian Health Board that we just, folks can just educate themselves and share with their communities the issues that we are We are trying to advocate for, just keeping up to date, calling your congressman representative, sharing the information with their broader community is always helpful, helping us educate and get our messages out there.
Okay.
Also, writing their congressional leadership and their New York State senators about the importance of Indigenous health is also a great way to contribute.
Okay. And we're still waiting for questions. And I had one question for, Abigail and AC. Early on in the administration, I think one critical piece, and you brought it up, Abigail, one critical piece is data. We rely on data to make policy decisions, to manage their health care. Unfortunately, in the DEI sweep, we lost a lot of health data, like you mentioned earlier, Abigail. What needs to be done to reclaim it and to house that data?
So there are active efforts across coalitions of every kind of community organization, research organizations, universities, who are pushing for the restoration and the full restoration of that data. It is really important for example, tribal epidemiology centers and tribal public health authorities, so tribes should have access to all data on our people, all of it, anything that has been gathered, so that we can use that information for the good and well-being of our people, and that access still does not exist. We need this administration to work with us to uphold that. But what happened after they removed data sets is some of them reappeared. And I want to bring up a key point of what reappeared. When they reappeared, some of them were missing key variables. So variables are part of what they gather in this information. And some of those key things that were missing was the gender identity specific of our LGBTQ plus Two-Spirit community, of those who matter so much to us. And I want to acknowledge that the National Congress of American Indians, in their executive session in February, had a panel of Two-Spirit leaders, which included leaders of organizations and also Two-Spirit identifying individuals who sit on tribal councils. And the Indian country stood up for and said, we are going to support our LGBTQ plus Two-Spirit community because we know that they're under attack. Our Two-Spirit community has always been present, regardless of colonization, across our tribal identities. Our transgender relatives deserve the same protections, love, care, and gender-affirming care specifically, which the removal of them in this data now creates for somebody like me who's looking at what do, for example, our LGBTQ plus community need in behavioral health? Well, if I can't find out information about them, then we don't know what resources and services we need to provide to them to ensure that they have their optimal behavioral health and that they have the opportunities they deserve. So I think it is essential for Indian country to continue to support, stand up for, and ensure that our Two-Spirit relatives know we stand with them.
AC?
Yeah, I think Abigail hit it. And it's essential information. We already struggle with what data we have that is accessible to tribes and to our techs and tribal epidemiology centers. And to have that information taken and distorted is problematic. So we are continuing to support efforts to get all of that data and information back. And like Abigail said, it really does impact the most vulnerable of our populations. And as American and Alaska Native people, we need every tool we have to make sure that we're protecting each other.
Mm-hmm. And I think that could probably partly answer another question that we have here in the chat. They asked, is there evidence that the Trump administration has violated, ignored, and not fulfilled, etc., any contractual obligations between the federal government and the tribes?
Well, I think that's a great question. I think from the very top, the treaties that the federal government entered into with the tribes is a contract. We paid in full with our land, with our resources for the provision of health and healthcare for our people. Whether it's stated like that in his exact words, it really differs. But that was a promise that was made, and that's a promise that has never been upheld through any administration of the United States. And, we have to work, and tribes have to work, to piece together ways in which to provide the resources needed to do their own, to fulfill all those obligations themselves, as we have for millennia. There's many instances in which programs have been frozen that provide direct funding to tribes through grants and other opportunities to urban clinics, to tribal clinics, which has caused a lot of disruptions. And that's, one of the greatest examples that we are following specifically.
Yeah, and I just want to say
They're cutting.
for the Trump
what?
administration, yeah, the Trump administration, I know we're talking a lot about the Trump, and we've seen much more significant changes than we've seen in several previous administrations. But there has never been an administration in this country that has fully fulfilled the treaty and trust obligations. They are in constant violation of those contracts that AC is talking about. But I do want to say that health in Indian country and upholding of treaty and trust responsibility is not partisan. It's not a Democrat, it's not about a Republican, it's about fulfilling those contracts and the treaties, which are legal documents that have, there's a recent 2021 district court decision that said that American Indians and Alaska Natives have a legal right to physician-led quality health care. We have that. It's just not being upheld. And we have incredible advocates, Republican advocates in the Senate, in the House, Senator Lisa Murkowski in the House, Representative Simpson from Idaho, who has consistently fought for the full funding of the Indian Health Service. And I just want to give a shout out to one of my favorites in the House, Representative Jake Ellzey from Texas, who in the work that I do also involves a lot of preventing violence against our women and girls, is in a recent hearing of the Indian Health Service. He is the only member of Congress who asked a question related to whether or not the Indian Health Service is going to have, in this instance, access to rape kits and what they have for our victims of violence in the Indian Health Service. So we have incredible Republicans and Democrats. It is not a partisan issue. We have to work together and build those collaborative partnerships.
Dean, real quick.
The only thing I would say is, when I used to basically recite exactly what Abigail said at CDC, you would see the looks from CDC staff that I would get, because they had no idea of what those contractual obligations are or meant, and fulfilling the trust responsibility for our tribal nations. So, but what the Trump administration is doing is that they're cutting Indian health through the back door. Although they're putting money up there and kind of funding Indian Health Service, I think at $8 billion, maybe some increases here, cutting some things there, they're kind of keeping things stable compared to the rest of the federal budget. But it's all the other agencies that are being pulled, right? CDC, SAMHSA. We could have a whole discussion about what's going on at SAMHSA. Maybe that's something that we could have it for another public talk. NIH, and many other federal agencies that are going on. So what the Trump administration is, they're not directly targeting Indian Health Service, and they're not. They're keeping stuff level funded, but they're coming through the back door, grabbing a little bit of funding here, a little bit of funding there, programs there. I know my colleagues in Arizona are getting hit, and their programs have been eliminated. One of them, Dr. Naomi Lee, and her care program in northern Arizona was just totally not funded. And, they have to lay off people. So, that's what's going on here in the Trump administration. They're not hitting us directly. They're hitting us through the back door.
Yeah. Well, thank you all today, all for your time today. It's all the time we have. I know we barely scratched the surface, but I just want to again for all of your time and energy and your work you do.
Thank you so much for having us.
Yeah, thanks. And a reminder to registered attendees, ICT will email you a resource guide with materials from health experts, so watch out for that in your inbox. And again, just thank you. And I'll hand it back to to Katie, our CEO.
Thank you so much, Jordan. What a great conversation. And thank you all so much for joining us today for our Pathways to Healing Town Hall. We are incredibly grateful to our guest speakers for sharing their time, insights, and expertise, and to each of you for showing up and engaging in this important conversation about the health and well-being of Indigenous communities. We truly hope you're leaving feeling more informed, inspired, and connected. I know I am. As a final reminder, we are a nonprofit news organization dedicated to elevating Native voices through free, independent journalism that centers Indigenous perspectives. If you found value in today's event, we invite you to support this work. Your donation, no matter the size, helps us continue hosting events like this, reporting from Native communities across the US and beyond, and training the next generation of Indigenous journalists. You can give anytime using the donation link on your screen or the donation link coming post-event messaging. And again, on behalf of all of us at Indig Public Media and ICT, thank you for being part of today's town hall. We look forward to seeing you at future events. Take care and have a great rest of your week.